So when discussing improvement measures with the Ansa, we go back to where the Ansa originated with Dr. Lyons from TCOM. So when we engage individuals in their families, transformation and change happens. And the work that we do helps one individual at a time and can help change our system. That helps us know what works and what it doesn't work and what maybe needs to be modified to help serve our patients. But we need to know what's happening, and by that we need to be able to measure that and all work towards the same goal. So why is it important to show improvement? Well, every day we're doing things to help those that we serve, and what we do makes a difference in those that we serve. But because we know that there's positive changes, we have to find a way to quantify that change through improvement measures. We don't have the individuals that are from the state in our clinics to see the work that we're doing. So we have to have a way to show the state. So when we show improvement, we continue to show HHSC, which is the Health and Human Services Commission, and other stakeholders that what we're doing makes a difference. The statistics from March of 2020 showed that we had 4,652 patients with an active Ansa in adult behavioral health. At that time, we had 852 patients that showed improvement indicated on their Ansa and 3,800 that did not show improvement by their Ansa. So that gives us about an improvement percentage of 18.31. Our goal set by the HHSC is 20%. So how do we show improvement? Like I said, the folks with HHSC and other stakeholders, they aren't in our clinic. They're not out in the homes. They're not with you guys to see the work that we're doing. And we can show that through goal achievement, patient report, staff report, but that's actually hard to quantify. So HHSC has determined that the scoring of the ANSA domains can show improvement with our patients. So what does that mean? Well, the domains that are reviewed for improvement include the risk domains, behavioral health, life functioning, strength, substance use, and trauma. And we're going to go through these in a little more depth. So how do we show improvement? In the different domains, each domain has different weights that need to be indicated for improvement. For example, under behavioral health needs, which is scoring a lot of the more symptom-related areas in a person's life, a person would need to improve by 4 points, which means moving from a score of a 3 to a 2, or 2 to a 1, or 1 to a 0. But they would have to score 4. Now, one thing to remember is that anytime a person shows improvement, if they show decompensation in a different area, those counteract one another. So that's one thing, the way the weights work. Life functioning is going to be 5 or more, but those are a lot easier. Risk behaviors only requires 2. And the reason that it has a lot of weight attached to it is hard to move and change the scoring on risk behaviors because a lot of them have history attached to them. Strengths is 6 or more. Substance use, which also includes the module, 4 or more points. And then trauma, 2 or more. And in the module, only the last 4 scores in the module are counted. And the reason for that is the last 4 areas for the trauma module are symptom related, and the others are history, which those will not change. So that's kind of how the weights work. Of course, even though we know the weights, we want accurate assessments of where the person is. But this is how the improvement measure does work. So a couple of guiding principles about the ANSA. The items on the ANSA are included because they're deemed relevant for shared decision making, interventions, and for wellness planning. And the ratings translate into action levels. You want to take into consideration a person's culture and their development when you're thinking about action levels. And before you are rating someone, take a couple things into consideration. Is there evidence of that need or strength? Are you considering the person's behavior within the normal development of their age? One of the things that we have to remember is that we are comparing folks to the general population. And one thing we can get guilty of is comparing our patients to other patients. Um, are you understanding the person within their normal developmental age, taking culture into consideration, and also what is the impact that it has on their day-to-day functioning? So reviewing the action levels. For action levels for need, a 0 means that there's no evidence that that's a need in the person's life or that there's no need for action. It doesn't mean that that problem or issue isn't there. It just means that there's no reason to believe that there needs to be action taken. Um, and action level 1 is watchful or waiting. That means that you're just keeping an eye on an issue or a situation. That could mean that a person has a history in that area, there's a suspicion, or that the patient report and what you know or reports of others conflicts, and so you can put a 1 as to resolve a source of contention. But 1 is basically that you're watching it, you're keeping an eye on it, or there's a history. For action level 2, that means there's some type of functional impairment. That means that it's impairing a person's job, their daily life, their ability to live independently. And then an action level 3, that means that this area of the patient's life is dangerous or disabling. That doesn't necessarily mean that the person is at harm to themselves, but that this is a really imminent need and immediate action needs to happen. So when you're thinking about assessing for needs, you want to think, is there evidence, suspicion, or history of this area of need? If no, then you're going to rate it a 0. If yes, then think about, is there evidence that it's interfering with the patient's functioning, and will you take action? If no, or you're not sure, you can rate it a 1, which means that there's a history and you're watching it. If you are going to take action and it's interfering in the person's functioning, then you can score a 2 or a 3 just based on how immediate the action is going to take place. And then switching gears a little bit, the action levels for strengths, they actually flip-flop here. So a 0 is a centerpiece strength. That's the strength that the patient focuses on in their recovery, on their wellness plan. And the way I like to describe it is that's what gets the person up in the morning. When everything else is crumbling around them, that's what keeps them going. And not everything in everyone's life is a strength. So that's the things that really get people going. Things that staff and patients have identified in the past trainings as some of their centerpiece strengths are things like their family, their faith, their job, things like that. Those are just the things that get you up in the morning. And an action level of 1 is a useful strength. That means that that strength is there, um, but it's just not as powerful. It's just not that thing that gets someone up in the morning. It's there, it's helpful, it helps them. It's just not as powerful of a strength. An action level 2 means that that strength has been identified, but it needs a little work. It needs to be built upon. And then an action level 3 means that that strength is not identified for that person. It's not a judgment. It's just that that is not part of that person's strength set. So thinking about assessing for strengths, is there evidence of a strength in that area? If no, then you rate a 3. That's not judgment. That is just where the person is in that area. If it's maybe, is it something that useful, can be useful but cannot be used today? Then you can put it as a 2. And then if it is identified as a strength, then will you be using it in planning? So rate a 1 or a 0 if it's that centerpiece strength. So let's talk about actually how to indicate improvements with those individuals that we are seeing. So a couple of rules for indicating improvement is you want to make sure you're not just copying the previous assessment. We want to work where the patient is currently. Consider the patient's diagnosis and symptoms and the time frame for the domains. You're working not with just history, but you're really getting a snapshot of where the person is in the last 6 months, and even more specifically, in the last 3 to 4 months. What has changed in their life? What things have gotten better? What things have not improved? What things have gotten worse? One thing to do is to focus on the 2 and 3 scores from the previous Ansa and see if those are areas that can have shown improvement for the patient. You can also ask the patient how they feel like they are doing and find those different domains where you can indicate the improvement on the ANSA. This is also a really great way to encourage hope with your patients by helping them find ways that they have improved. So in the life domain functioning, taking into consideration the different domains. So if you're talking about the family relationships, has the patient's family relationships improved? Have they reconnected with family members or gotten closer with family? If they have, let's indicate that by showing improvement in that area. For physical and medical, has the patient's physical health improved or have they connected with a medical provider? If they have, let's indicate that on the ANSA under the physical and medical area. In employment, employment is not just if a person got a job or not, but has their job situation improved? Maybe they gained employment. Maybe they've gotten a promotion. Maybe they've got an increased satisfaction in their job. Maybe they have less barriers to go to work or less negative interactions with their boss or colleagues. Anything that's improved a person's employment can be indicated here. For social, has a patient's social situation improved? Have they reported spending more time with others, spending more time outside the home, increasing those relationships, or even seeking out those relationships? And then, of course, recreational. Has a person become more involved in their hobbies or other recreational activities? If they have, indicate it in the recreational area. For living skills, is the patient able to live more independently? Are they able to pay their bills? Are they living with minimal assistance? Are they more integrated into their community? If so, indicate in the living skills. Residential. It doesn't just mean has a person gotten housing or not, but it could be have they gained independent housing? Have they seen an improvement in their housing situation? Or have they been able to better manage their housing needs, such as paying their bills or taking care of their residents? For legal, has the patient had a positive change in their legal situation or status? Have they come off paper? Have they settled a court case? If so, let's indicate that in their improvement. And then in sleep, has the patient had an improvement in their sleep patterns? If yes, then indicate this. Self-care. Is the patient better able to manage their activities of daily living? Can they take their medication without prompting? Or is there a noticeable difference in the person's physical appearance, such as hygiene, pride in personal appearance, or even personal grooming? And then transportation. Is the patient able to find consistent transportation? Or are they able to find independent transportation on their own? And then involvement in treatment. Is the patient actively involved in their treatment? Are they actively pursuing their goals for their recovery? Let's talk a little bit about behavioral health needs and how historical ratings go in here. So for your behavioral health needs, has the patient reported an increase in symptoms or an increase in the ability to cope with the symptoms or situations? Now, there are historical things in this area. So for psychosis, a person who has a diagnosis of schizophrenia or schizoaffective disorder will always have a rating of 1 for history. For a person with major depressive disorder, they will always have a historical rating of 1 in behavioral health needs on the depression area. For anxiety, if a person has an anxiety disorder, they will always score a 1 for history in this area for anxiety. Another one is mania. If a person has bipolar disorder, they will always, at a minimum, score a 1 in depression and in mania because they have bipolar disorder. For a person with adjustment to trauma, if they have a diagnosis of post-traumatic stress disorder or PTSD, they will always score a 1 in adjustment to trauma. Now, one of the things about the trauma module is the last 4 ratings in the module are symptoms, and those are the ones that can be indicated for improvement. Antisocial behavior needs to be taken in consideration that this is not a person not socializing. This is going to be actual antisocial behavior, which by definition is a person who behaves without regard to the consequences and what it imposes on other people. This can be things like criminal activity, harm to others, things like that. This is not rating how social a person is, but if a person has antisocial personality disorder tendencies. Another one that gets scored incorrectly a lot is eating disturbances. This is going to be a person that has a diagnosed or suspected diagnosed eating disorder. This would be anorexia or bulimia. So while we do have patients that do fit this demographic, a lot of our patients do not. A lot of times this gets scored because of eating related to a person's depression or other symptoms or life situations. This is not emotional eating or anything like that. This is going to be someone with a eating disorder. And in substance use, if a person has a substance use disorder, they cannot be scored less than a 1 due to history. However, if the person has been clean and sober for over a year, they can be rated at a 1. And thinking about our risk behaviors. For risk behaviors, we have suicidal risks, non-suicidal self-injury, self-harm, exploitation, danger to others, gambling, sexual aggression, and criminal behavior. Has the person shown a reduction in risk behaviors? Again, these are hard to show improvement because they have a lot of historical factors, but you want to take into account if this is not a posed issue for them at the time, you can put it at a 1 for history. And then our strengths. Is the patient utilizing an increase in utilizing their strengths? So things within family, social, their optimism, education, resilience, all of those things. Are they showing a increase in using those strengths? If so, let's indicate that on their improvement. So I want to challenge you for your next assessment. Have the patient or help your patient identify 3 or 4 areas which they have improved in the last 6 months. Not the past week, days, or months, but in the last 6 months. Sometimes people will come in and they're having a crappy day, but in the last 6 months, have things improved for them except for this day? And if so, you want to indicate that on the answer to show improvement. So now I'm going to stop and I'm going to take time for your questions. So you can either unmute your mic or you are welcome to put your questions in the chat.